everyone. Welcome back to what's our podcast called? ECTopics.
Has it been that long?
Oh my god, that was actually not
It's
intentional.
been so long you forgot how we do our topics.
I don't know who I am.
Let me start.
Okay, go.
Hi, I'm Nurse Rob.
Hey guys, it's Nurse Amy and Nurse Rob.
Welcome to
ECTopics, the
Oh,
podcast.
you suck at this. Let's do this again.
What?
Hi, I'm Nurse Rob.
Hi, it's Nurse Amy.
And welcome to
ECTopics, the podcast.
Podcast for Nurses and Paramedics.
That's right, yes. So I know.
It's been a hot minute.
A really long, hot minute, and
That's a sleigh.
it is not a sleigh, actually.
It's not a sleigh. I got my sleighs wrong.
Yeah, but look, we just wanted to say hello. It has been a very long time since we've been doing the pod. So much has happened, actually. You've been to Alaska. I've been to Japan. I got engaged, really random.
That was random.
I got reported to opera. That's also really random.
Oh, line up.
Quite funny. I know.
Nurses all over social media are getting reported to APRA. We
So-
will talk about it one day, but at the moment it's still playing out.
Yes, I do have to be very careful about what I say.
Yeah.
What's been happening in your life, Dink?
Dink. Well, what's the Dink been doing? I don't normally refer to myself in third person. It feels very awkward. Okay, so
Yeah.
what have I been up to? Well, I've done some very interesting courses around the place.
Yes.
Since the last podcast that we did, we've been to Adelaide.
Yes, so we got to meet Nurse Tay. That was
Nurse Tay in Adelaide. That was pretty
epic.
cool. We went. I've been down to Gosford
Mhm.
and Dubbo in
Jabbo.
New South Wales. That was exciting. I have done. No, it was really exciting. I did an amazing event at an aged care facility up in Tully,
Yes.
near Cairns, sort of south of Cairns, and that was our aged care program. One of the, I'm not allowed to mention them because there's commercial in confidence, but one of the very large aged care providers in Australia have reached out to me to provide their nurses with some aged care education.
Yes.
So that's very exciting. I
Very.
love teaching that aged care stuff. So I've got some aged care courses coming up. Excitingly, I have got some courses coming up in some exciting places like Bali,
Yes, and we're going to Fiji in
Fiji.
October, and I get to go.
Vietnam.
I'm very excited. So lots of exciting things are happening. I have been blissfully away in GP land for the last 6 months.
Now tell me, what have
which-
you been learning in GP land? You've been doing courses.
I have been. So I have finished my immunisation course for nurses. So I'm technically a nurse immuniser, which is very big deal, guys. And
Hey, did you know they're not called vaccines anymore?
yeah, oh my god, yes.
Isn't it funny how they keep changing the terminology?
So they're now called immunisation medicines,
That's right.
which is funny, but anyways,
We should.
we should. That is the correct
Because we are
term.
all about keeping up to date,
To date
not
with
carrying on the banter of the dogma of the old,
correct.
which I don't even know what that means, but it sounds quite poetic.
It does. Yeah, so I've been in GP land, which has actually been really fun. I'm gonna just say it, I've got one of the best workplaces. My work-life balance right now is iconic, and I'm getting so much sleep. Wow. Thank God I'm catching up now.
Can't wait to get you back on night shift.
Yeah, it's going to be so fun. Yeah, so I have been doing heaps of wounds. I've done an ear syringing course. I was really into ears for a while.
We've got an ear, nose and throat workshop.
Yes, well, I'll definitely come to that. I don't know how much teaching I'll be doing just yet, but yes. And another very exciting thing is we did a little talk at ACU a couple of, probably about a month or two ago now.
That was good.
And we're going back to ACU very, very soon on the 6th of October, actually, which is Monday, to do a ECG course workshop for student nurses. And that is not limited to ACU students. It's actually open to nurses and nursing students who want to come. So it's $40 per person if you're
And
not.
paramedic students.
And paramedic students, and medical students. open to everyone if you are interested. It'll be at the ACU campus. We're just waiting to get word from what room we'll be in, but once we do, we'll be posting that all over our socials. So yes, that's very exciting. We're excited to do a little ECG course for everyone.
And getting to meet some people.
I'm so excited to meet people because yes, we've got
Oh, there's so many people. But you know what was really exciting for me? I had a bit of a fangirly moment. In fact, we both had a bit of a fangirly moment. We had the opportunity to go and see Nurse John.
That was so
when
fun.
he came to Brisbane, and that was good fun.
That was
But
so good.
waiting in the foyer before the show,
Yes.
so many people came up to us and said, "When are you doing the podcast again?"
I know.
We've been hounded
We have
by people who recognised us from social media.
To be honest, it wasn't that we didn't want to do the podcast. It was just genuinely
life got in the way.
Life and a lack of resources, which actually brings me to my next point, and that is I am sorry for the quality of this, but we are in the process of getting some new equipment, which will hopefully elevate the podcast recording experience and listening experience for all of you. And hopefully we're going to get back on the bandwagon of the podcast very soon. So that is lots of exciting things are happening. But another exciting thing is Dad has been offered an opportunity to do some hyperbaric work.
Oh yeah.
Yes.
Well, from time to time I go back on the tools, so I'm going to be rehashing my skill set as a hyperbaric nurse working in the recompression chamber or the hyperbaric oxygen centre
So
in Brisbane. So that's exciting. Looking forward to doing that.
So can you tell us a bit about hyperbarics? Because as a new nurse, especially me, and for anyone who doesn't know, because I feel like it's such a niche area, let's talk a bit about hyperbarics. What is a hyperbaric chamber? Because it sounds kind of like a torture chamber.
Well, it can be if you don't like closed spaces.
Yeah.
Okay, so it's hyperbaric oxygen is the therapy. Now, the same oxygen that you're breathing right now is 21% oxygen. If I put 100% oxygen on, like let's say I put an oxygen mask on you and I was giving you 100% oxygen, then you would be breathing essentially 5 times the amount of oxygen that's already in the atmosphere, 21%, right? Well, is it possible that I can give you more than 100% of anything? And the answer is technically no. So, but what if I put you on 100% oxygen and I took you down in atmospheric in depth, in terms of like scuba diving depth, if I took you down in pressure and I gave you that oxygen in a high pressure environment, and that's what hyperbaric literally means. It means high pressure. So we give 100% oxygen to patients somewhere between 10 and 18 meters deep. And that's the equivalent of about 2 to almost 3 atmospheres of pressure. So it's like 2 to 300% oxygen, right?
Wow, that's amazing.
Now, when I give oxygen at that high concentration, oxygen actually takes on a few drug-like properties. First and foremost, it's toxic to bacteria that don't like oxygen. So it acts like an antibiotic that can get to certain wounds that are infected by the types of organisms that shut down blood supply.
So a bit like diabetic foot ulcers or diabetic ulcers in general, chronic wounds.
Well, anything that's got really poor perfusion.
Yeah.
We can dissolve enough oxygen into the juices around the wound, not just deliver it by oxygen. Remember, if they had good blood supply to their wound bed, they'd heal.
Yeah.
But because they don't have good blood supply, delivering oxygen via the blood's not going to be effective. So we supersaturate the patient's whole body. It's think of every liquid in your body becomes supersaturated with oxygen. And that higher concentration of oxygen is enough to sustain and switch on a number of properties. Wound healing turns back on.
Yeah.
Those fibroblasts that make all of the collagen fibers and knit wounds together, they turn back on.
Yeah.
Brand new blood vessels start to grow under that high oxygen environment. So these patients are treated typically in a chamber for 30 or 40 treatments.
Wow, that's a lot. And how long are the treatments normally?
Well, they're usually about 90 minutes.
Are people naked?
No, they go in, we put patients in scrubs. They have to be in non-sparking clothes. So clothes that don't have any static, right?
Right.
Which is part of the whole reason why, for generations, people in an anaesthetic environment, like an operating theatre, have had to wear low sparking
Sure.
clothing, right? You don't want anaesthetic gases and
No.
high oxygen concentrations and sparks. They tend not to
Yeah.
go well together.
Not friends.
It makes their burn.
Not a sleigh.
Makes their burn. So a patient is treated inside the chamber. They don't have their wounds exposed in the chamber. So outside of the chamber, there is a wound room. And typically, one of the wound nurses will do their wound, will clean their wound and redress their wound, take obs and swabs if necessary. Then the patient the wound is dressed and the patient comes into the chamber. They sit in like a recliner chair, just the sort of chair that most people would have in their lounge room and watch telly. And they will sit in that chair, and then we place a hood over the top of their head that's completely clear, completely see-through, has no blind spots, a little bit like a bit like a space helmet.
Really?
Yeah, a little
That's
bit.
so funny.
Yeah, I'll show you some photos of it. But yeah, it's a little bit like a space helmet, and then we pipe oxygen through the hood, right? So they're breathing 100% oxygen in a room that's then pressurized. Well, we pressurize the room before we put oxygen on. So we take them down to the depth that we're going to.
See, in my brain, you're in like an elevator and you literally go down.
And in my brain, it's like that too. But the room doesn't go anywhere. This is many thousands of tons of steel. It goes nowhere, right?
Yeah.
So it's in the basement of the hospital because there's no way they're going to stick that in a forklift and lift it up into the first floor.
Like a big steel room.
A standard sort of, a standard bedroom size, 5 by 4, I suppose, maybe 3 by 5 meters square. And inside it, I want you to imagine that this room didn't have a big bed in it, but it had 6 recliner chairs in it.
Really? So the patient just chilled, like you just sit and chat?
We can treat up to 8 people in the chamber. Now, a nurse goes inside the chamber with the patient.
Yeah.
And that's because, remember, oxygen is a drug.
Yes.
And the higher the concentration or the higher the dose of a drug that you give, the more potential there can be for side effects. And one of the side effects of really high concentration oxygen at pressure, at depth, is fitting. Oxygen can be toxic to brain, and it can actually induce an oxygen-induced seizure.
Wow.
So, ironically, what do you think we would do if somebody had a fit while they were on hyperbaric oxygen?
Midazolam.
Well, absolutely. So all the same drug therapy.
So you've got all the drugs inside.
But the question is this: if the oxygen caused the fit, what would we immediately take off when they're fitting?
Of course, the oxygen.
So there needs to be a nurse inside the chamber to flip them off their oxygen.
Sure.
So that the fit can
do you have to do that slowly, kind of like when you rise in a scuba, like when you're scuba diving? Do you have to? You don't. You can just switch it off.
No, oxygen just off and on.
Yeah. So like a ward, you can just switch it off and on.
That's right.
Yeah.
And so the patients so we go down in depth, and that might take 5 to 10 minutes to get down to the depth that we're going to treat at. Let's say it was 14 meters. Standard wound treatments are about 14 meters. Yeah. The patient will go on oxygen for 40 minutes, and then we flip them off oxygen just to breathe room air. And that's to reduce the amount of oxygen in their blood, just to give extra insurance so that they don't have any fitting.
Oh, okay.
Yeah. Now, I've been involved in the hyperbaric industry for many, many years, and I've only ever seen one seizure.
Wow.
From oxygen, and that was particularly deep.
Were
That was
they
a patient
okay?
treated at 18. Yeah. Look, most fits are benign. I know they look violent.
No, they do.
Even febrile convulsions in most cases are benign. There's the very, very rare occasion that a seizure can cause damage if it's prolonged. But no, a cerebral oxygen toxicity seizure is something quite benign. We pop them off oxygen. There's generally no sort of side effects, and the fit stops within seconds to minutes.
Fitting
often before you can get midazolam drawn up.
Fitting is quite scary to see.
It's very, very frightening to watch.
I remember one of my days in ED, I was having not a good shift, and 2 of my patients, like one after the other, were seizures or fitting, that we saw, and it's it's quite scary to watch, especially when you're new to it and not really sure what to do. But um, I actually have so many questions about this hyperbarics. So, do you have to go down, well, quote unquote, down,
Yep.
like
Be
slowly?
pressurized.
Do you have to do that slowly?
Well, the short answer to that is yes. I mean, there's only so fast that you can pressurize a big room.
Mm,
Yeah. So it's quite a slow, it's called a descent. So all
mm.
this terminology comes from the diving industry.
Yeah, yeah,
And of course, I mean, we should really talk about the elephant in the room, and that is yes, we do use the same chamber to
for the
treat people
bends.
with the bends
Yeah.
who have diving injuries.
What's the full name of the bends?
Decompression illness, type 1 and 2,
So where does
depending
the
on
bends come from?
when so it was they were called so the Kazon work. Do you know what a Kazon is?
No.
It's kind of like a big tube that they plunge down into the ocean, and then they pump all of the water out of it when they're building like footings for big bridges.
Oh, okay, yeah.
So if when you look at the big bridges around the Brisbane River,
Mm,
how do they get right down the bottom and pour concrete
mm.
in there? They've got to pump water out to make
Right,
concrete set,
yeah.
right? So they plunge down these great big tubes called Kazons, and they're big enough for people to work in. And so the Kazon workers would work down, they'd pump the water out, but they would still be technically under pressure, right?
Mm,
They might be so many, meters deep, and they would work all day, doing their welding and their bridge footings and their whatever they were doing in these Kazons. And then they would come out of the Kazons and they'd surface, but they surface so quickly that while they were down for all of those hours, their body would absorb the nitrogen from the air that they were breathing. Just
mhm.
like your body is fully saturated with nitrogen now at sea level. If I took you down to, say, 10 metres under the sea and you were breathing air, because that's what they're breathing down there, that's what a scuba diver's breathing.
Yeah,
They're breathing
yeah.
air, they're not breathing oxygen from the tank. They're breathing air, which is 80% nitrogen or 79% nitrogen.
Mm,
Your body starts to saturate you become super saturated with more nitrogen, right? So
mm,
that nitrogen goes into solution. It doesn't form gas bubbles, it's into solution in your juices, in all of your fluids in your body, absorb that nitrogen so
mm,
that your joint synovial fluid, the capsules in all of your joints, your blood, any liquids in your body at all start to absorb nitrogen.
mhm.
Now, that nitrogen absorbs very slowly over many minutes to hours. Now, if I surface too quickly, just like taking the lid off a can of soft drink or a cork out of a bottle of champagne, all of that dissolved gas, what happens when you shake up a bottle of Coke and you just look at it while it's shut? No bubbles.
Yeah, but when you take the
But as soon
cap
as you
off,
take the lid off the Coke, suddenly you have released the pressure that's on the inside of that, and all of the gas, that carbon dioxide, comes out of solution in the Coca-Cola, right?
mm,
And it becomes bubbles. It becomes a
mm,
fizzy drink. It was never fizzy inside the bottle. Look at it
mm,
next time you're looking at some champagne or some
mm.
prosecco. There's no bubbles in it until you take the lid off,
Yeah, yeah, yeah,
right?
yeah.
It's that sudden decompression that does that. So what these Kazon workers would do is they would go down and be breathing nitrogen for a whole day, working in the Kazon, working on the footings or in the mines. They would then surface too quickly because they didn't know not to. And by the time they got to the surface, all of the bubbles would start to form in their joints. And when the bubbles
Oh.
formed in their joints, they were bent over and crippled with pain. And they would walk with this claw-like painful gait because they had all these bubbles forming in the joints of their hips and their knees and their elbows and all over their body. They would have these bubbles forming in their body, and that was the bends. They were bent over, and that's where the term the bends
Wow.
comes from. So it was seen originally in Greek workers working on Greek, mine sites and building, bridge footings.
Mm.
So it takes its name from the Grecian bends, from the Kazon workers, the Grecian bends, because they were Greek
Oh.
workers. It's a fascinating
That would
history.
be obviously a really, really severe case of the bends, whereas a mild case of the
Well, that's
bends.
actually funny you should say that. That's a mild case of the bends.
Oh my
Severe
gosh.
cases of the bends is the bubbles form in your spinal cord, or
Um,
they form in the brain.
Yeah.
And when they form in the spinal cord or the brain, this can cause permanent paralysis or death.
Oh, that's really
And
grim.
so this is the thing. So every scuba diver is taught that when they go scuba diving, there's only so much time that they can spend at certain depths. So I can go
Mm,
for a scuba dive at, say, 12 meters deep, and I'm
mm.
quite safe to stay down there for an hour, but I couldn't go to 20 meters deep and stay for an hour. I would have to come up a lot slower and do safety stops as I surface to allow my body to off gas that nitrogen to prevent it necessarily coming out in bubbles while I'm sitting back up on the boat. And I'm also taught not to, scuba divers will be taught that there's a maximum amount of dives you can do in any one day. It's also why you can never fly to altitude. You can't ever get in an aeroplane after you've been diving for a day.
Really?
So one of the interesting things in the chamber is that most of the people who we treat in the hyperbaric chamber with the bends, with scuba diving induced bends, are often divers who have come down from a place where they've lived at altitude. So they might live, say, up in Toowoomba.
Oh,
They've gone diving, say, at the Gold Coast
right.
or
So
the
gone
Sunshine
down.
Coast. They've done a whole diving weekend, so they might have done 4, 5, 6 dives over the course
Mm,
of a weekend, which is not dangerous in and of
mm,
itself. But on the drive home, when they went up, back home up to Toowoomba, which is
mm,
700 meters above sea level,
mm.
that change in altitude has actually now dragged more gas, nitrogen, to form bubbles in their joints, and they often will present with malaise and aches and pains and just be really, really sore and feel like they've been run over by a bus.
Have you ever had it?
I've never had the bends. No, I wouldn't be able to. I wouldn't be able to be a hyperbaric nurse if I'd been bent.
So what training do you have to do to be a hyperbaric nurse?
Most hyperbaric nurses will do a minimum of a 1 or 2 week training course that involves
Hmm.
quite a fair bit of physics, gas physics and Dalton's law and
I would
Boyle's
hate
and
that. I'm
well,
sorry, but that's
you're
my
not
work.
into your physics, but I'm a bit of a science geek.
Yeah.
Yeah. Um, Most hyperbaric nurses have some degree of a critical care background.
Hmm.
So either they're passionately interested in wounds or they're an ED ICU nurse. Because remember, the sickest of our patients, may be ventilated.
Yeah.
And you can't take an ICU nurse and put them in a chamber. They have to be trained as a hyperbaric
Yeah, of
nurse.
course. Yeah.
So the majority of hyperbaric nurses will have some degree of critical care skills and should probably be. I mean, it's a blanket statement,
Mm.
but I'm going to say it. So I'm not trying to be offensive, but a hyperbaric nurse will also be a critical care nurse because they have to be able to care for somebody on a ventilator
Mm. Sure.
inside. And the interesting thing is the ventilators we use inside of a chamber are quite primitive. They're old-fashioned ventilators. The new modern ones are not safe to go in a chamber. They
Wow.
get damaged by the pressure. But, old oxylogs.
So you have to be really old to work there too. So you fit in really
No,
well.
you just have to
I'm
be
kidding.
somewhat experienced in multitudes of different
I'm
technologies.
kidding, everyone. I
So
don't
we do
think
a
you're
hyperbaric
old.
course. There is a program that you can do through a number of universities. I think one of the South Australian universities does a graduate certificate, a grad
Mm.
cert in hyperbarics. Um,
It's really interesting.
and then there's quite a grueling medical that you've got to go through. You've got to have audiometry done, ear testing, chest X-rays. There's all of that
Really?
stuff. You've got to achieve an industry standard commercial diving fitness
And do patients have
fitness
to
to
go through
dive.
that as well before
No,
they? Okay.
no, because they're not working in that environment.
Right, so they would only have their treatment and then hopefully wouldn't need it again.
Yeah.
And what kind of?
So if we were to talk about a standard treatment
Yeah.
for somebody with a wound,
Yeah.
right? So core business would be treatment of people with diabetic ulcers
Mm-hmm.
and people after they've had radiotherapy for cancer. Often that radiotherapy causes breakdown of soft tissue around the
Mm.
site that's been irradiated. It's kind of like a collateral fallout in an attempt to try and zoom in and kill the cancer cells. You also kill otherwise healthy tissue
Yeah,
around it,
a
and
few
then
of our patients have unfortunately had some really nasty post-radiation wounds.
yeah, so that's called radionecrosis.
Yeah, it's
And
awful.
so there is soft tissue radionecrosis, and there's also osteoradionecrosis, which is where bone disintegrates and breaks down.
Mm.
Well, you can't heal that bone if it's got no blood supply. And so hyperbaric oxygen is used for those patients to regrow their blood supply. It stimulates the growth of new blood vessels. It's called angioneogenesis.
Love that word.
No, you do. It's one of your
Angioneogenesis.
favourites, yeah.
So is catharsis.
So, yeah,
I'm really into catharsis at the moment. I just think it's a really awesome word.
too good. Yeah. So, radionecrotic injuries, diabetic ulcers, that's kind of core business. Arterial ulcers, people have difficulty with vascular ulcers. Yeah. It's also used for necrotizing infections. So those sort of infections that are caused by bacteria that hate oxygen.
Necrotizing fasciitis.
Like necrotizing fasciitis,
so
Fournier's gangrene,
awful.
gas gangrene, Clostridium perfringens, all of those really nasty.
That's a big word.
Oh, look, I'm full of the big
Really
words.
feel, yeah. Talk about swabs as well.
What sort of swabs? Like wound swabs?
Maybe it is common knowledge, but when you take a wound swab, you're supposed to do it once the wound is clean. You're not
That's right.
taking a swab of all the gunk.
No, that moniaca is debris. That's not often
That's not bacterial.
No, well, I mean, see, it's a bit of a misnomer that pus is full of bacteria. Pus itself is...
It's just dead
is-
macrophages.
Well, macrophages, neutrophils mostly. Those big white blood cells that kill bacteria. So you really should be cleaning the wound adequately first.
Yeah.
And then what you need to do is you need to place your sterile sort of Q-tip applicator
Swab.
device that's on the end of the swab.
Mm.
You need to place that into the center of the wound so that it doesn't touch the wound's margins. So think of a wound like a pizza, right? It needs to go in the middle of the pizza, not on the edge of the pizza. And you have to push down the swab into the Q-tip, I suppose, down into the wound with enough pressure so as to elicit some ooze from the wound bed. And then roll the Q-tip over so that it collects the juice that's being squeezed out from under the wound surface.
Right.
So you're not dragging it across the wound surface so as to scrape off skin cells.
You're kind of pushing down.
You're pushing down and you're trying to squeeze the juice out from under it, because that's where bacteria that are colonizing the wound live, and they live under that biofilm, that sort of glucose protein layer that bacteria make, this stuff called biofilm. That prontosan that we use on wounds?
Yeah.
That cuts through the biofilm. Biofilm's kind of like the bacteria's armor.
So then,
And it also hides the bacteria from the patient's immune system. So the immune system doesn't know that the bacteria is there. It's kind of like a camouflage. So we're trying to squeeze bacteria antigens out from underneath their biofilm so that we can take that and send that to the lab. Now, if we can get some good bacterial organisms on that swab, what the lab's now going to do is they're going to culture it, so they'll do microscopy on it. So it's called MCS, isn't it? So microscreen, culture, and sensitivity. So they'll do microscopy. They'll identify under a microscope what is the organism. So what's the bacteria? Let's say it's infected by Staphylococcus aureus, golden staph. Okay, well, we find that it's golden staph. Now we're going to grow the golden staph. That's called culturing. So they actually stick it on those little agar plates. You remember doing that in high school, in petri dishes, and growing bacteria. So they'll grow that, and then they'll they'll grow many colonies of that staph, and then they'll try and kill the colonies with different types of antibiotics. And whichever antibiotic doesn't work, well, that's where we say that culture is resistant to that antibiotic. So if I grew a whole lot of golden staph on a whole lot of agar plates and, put 10 different antibiotics on to try and kill it, and it only responded to one antibiotic, you could fairly say that those other 9 antibiotics are not going to be useful.
Yeah.
And then now you've got a multiple resistant Staphylococcus aureus, or MRSA. Does that make sense?
Yeah.
Yeah.
Which we don't want.
Which we don't necessarily want. Nobody wants
No
it.
vibes. Bad vibes.
Bad vibes. That's not a sleigh.
Honestly.
No.
Yeah, so wound care is really interesting. I think that, like, when you think of a wound, you think, oh, I'm going to clean off all the gunk on it, and then it's clean. But, it's clean from the surface level, but when you really look at what a wound is, you kind of do have to kill the bacteria from the inside out.
Well, that's right. You've got to support the patient's blood supply as well. So a
Mm.
lot of bacteria will hide behind this idea that if they can produce chemicals that shut down blood flow,
Mm.
then white blood cells can't get to them to kill them. Right?
Mm.
It's all part of that kind of that biological warfare that's going on in a wound. And so I guess if we can circle back to the conversation around hyperbarics, when would you as a nurse think, I wonder if this patient would be a candidate for hyperbaric oxygen?
Mm.
Well, all major cities in Australia, all major capital cities in Australia have hyperbaric oxygen chambers that are itching to have wound patients referred to them. That's core business in a recompression chamber.
Mm.
And so what we're going to do is we're going to encourage you as a nurse to say, this is a patient whose wound has not moved forward for weeks.
Mm.
In a normal situation, somebody with a healthy blood supply, a wound should just switch on and start healing.
Mm.
Yeah? Unless it's being constantly traumatized by, being cleaned roughly, or people are putting, chemicals on the wound, thinking that they're cleaning the wound, but it's destroying the wound.
Yeah.
And sort of the number one thing to avoid when we're doing wound cleaning is, of course, an antiseptic. We should get rid of that chlorhexidine. It's not supposed to be used in the wound.
Mm.
Yeah. We should also be thinking about, is this wound demonstrating any symptoms of infection? And so if infection is present, can you see clear up the infection? The wound just might switch on and start healing again.
Yeah, of course.
So if you've got a non-infected wound that just doesn't seem to be doing anything, it's not moving forward, it's just not healing, it might just be a candidate for hyperbarics, and refer it.
Why don't we use chlorhexidine?
Well, chlorhexidine is cytotoxic. So think about a wound bed. Think of an ulcer bed on a patient with a venous ulcer.
Mm.
Once we clean that ulcer bed, we should be using irrigation.
Yeah,
Right? So
yeah.
warm saline or warm tap water irrigation for wounds. So we clean that wound off. If we put chlorhexidine onto that wound bed, the premise would be, why are you using an antiseptic? Are you worried that it's infected?
Mm.
Okay. Are you worried it's infected? And if you're worried that the wound's infected, then the wound isn't healing. It's in a state of dormancy.
Mm.
An infected wound doesn't move forwards. It either stalls or it goes backwards, doesn't it? And it's in an infected wound that it would probably be okay to use something that is antiseptic. And whether you want to play with iodine, like cadexamer iodine, iodazorb, or one of those, whether you want to use something along the lines of a povidone iodine, like a betadine type product. I'm not advocating for these. I'm just saying that use an antiseptic when your wound is septic.
Right.
But if you've got a healing wound
You
and
don't
it just
want
needs to be cleaned,
it's overkill.
well, it's not overkill, it's actual kill. You are killing those brand new endothelial cells with chlorhexidine or iodine.
Oh.
So healing wounds are doing exactly what you want them to do. Why would you want to poison that?
Yeah, no, I only ask. The only time I've used chlorhexidine is to clean a possibly infected suture line.
Exactly.
Yeah.
And that would be absolutely reasonable. But you think about why antiseptics were developed. They were never developed to put in the wound.
No.
They were always developed as a skin prep. Something that you would paint on intact skin before you cut them open in surgery.
Yeah, that's the other thing, is our doctors use them before they do excisions all the time.
And that's quite reasonable.
Yeah.
That's what they're for. Antiseptics are designed to clean the skin before you go through the skin. But in a patient who's got a wound, the premise is they've already denuded their epithelium. They're all the way down into, they're below their dermis. They've got a full thickness wound. Those very, very delicate fibroblasts and skin cells that are budding up from the base of the wound, that beautiful granulation tissue, that's destroyed by chlorhexidine and betadine.
Yeah, sure.
So it's counterproductive. We're wanting to promote wound, tissue growth. We shouldn't be trying to send it backwards.
Yeah.
That makes sense?
Absolutely.
Yeah. And I guess this is the big thing. We think, oh, it's a mucky wound. Well, is it mucky? or is it mucky and infected? Because if it's
Yeah,
infected,
exactly. There's a
then
difference.
something that's antiseptic is a reasonable choice.
Yeah. And slough is actually a good sign of healing
Well,
sometimes.
slough is an indicator that something's happening.
Yeah.
Often slough is actually part of, part of the stripping or the sloughing off of the dead tissue. We
Yeah.
want to essentially autolyse. It's sort of an autonomic debridement that's going on
Yeah.
there.
Yeah.
Um,
I love debriding a good wound.
yeah.
It makes me so happy.
But, here's school for thought. We can finish on food for thought.
Let's finish on food for thought.
We are the only mammal on the planet that thinks that it needs to put a dressing on its wound.
Mm,
Every other animal on the planet heals its wounds with no intervention but licking. Now, I'm not suggesting we all go out and lick our wounds. And please don't lick your patient's wounds. That would be a no-no. But it's a really interesting thought. The body knows what to do. Our role as wound care nurses is to cover the wound and keep it clean and just let the bloody wound do what it does.
yeah, let
All
it do
right?
its thing.
Let it do its thing.
Yeah,
Good
that's it.
chat.
Yeah. Well, thank you guys for listening if you've gotten this far. Thank you for listening. We will aim to definitely do another recording in the next couple of weeks. We are currently away in Western Australia. We're actually in Albany, a little
Albany.
town. It's very cute.
It's a very, very nice town.
And yeah, so we will aim to upload soon, and we hope to see everyone who wants to come at ACU on the 6th of October. For any more information, we'll be posting about it on our socials as well.
Oh, can I plug our trauma course?
Oh, yes, plug.
We've got a trauma course coming up in November in Newcastle. I want to get down to New South Wales. I'm going to meet you all from Newcastle in that area. So all you Sydney girlies who want to do some trauma, come up to our trauma course in Newcastle, and of course all of those from around the Hunter region.
Yes.
Newcastle for trauma.
Thank you guys for listening. This has been Nurse Amy.
And I'm Nurse Rob.
Have a wonderful day and keep slaying. Bye.